Welcome to the Deborah International webinar session. The webinar today is on physiotherapy in Epidermolysis bullosa clinical practice guidelines, which were published in October 2021. Please do enter any of your questions in the Q&A and we'll try and address them as we go along, and any will be answered at the end of the session. If we missed any of your questions, I will use my particular email address, which Olivia Mullins will share in the Q&A for you to write to me, and we'll address any questions that we haven't been able to cover. So it is my pleasure now to introduce to you Dr. Amy Wiseman. She has been a physical therapist for 18 years. She is a US board certified pediatrics clinical specialist and has been in Stanford Children's Health since 2006. She joined the Epidermolysis bullosa specialist clinic at Stanford in 2016, where she is the primary physical therapist. Thank you, Amy.
Good morning, everyone. Welcome. Again, my name is Amy Wiseman, and I do have no conflicts of interest to share. Next slide. So, we know that with epidermolysis bullosa, that there's considerable variations that exist in disease severity. Therefore, persons with EBs show and present with a wide range of disabilities in scarring, fibrosis, contractures at various joints. There's pain and itching. And we know that when movement becomes uncomfortable and painful, it leads to restrictions in the joints and can affect daily function and ultimately everyday life, which, this can impact mental health and wellness, which can cause loss of functional capacity and ability to actively participate in society, which we can know that this can affect the quality of life. Next slide, please. So in physiotherapy, it is the science and art of physical or corrective rehabilitation, excuse me, and it specializes in the movement sciences and aims to enhance or restore function of multiple body systems, including the musculoskeletal system, nervous system, and the cardiovascular system. Next slide, please. Highlights of physical therapy practice or physiotherapy practice is that, the clinicians and providers work in preventing disease, injury, work on managing acute to chronic conditions, activity limitations, and participation restrictions. We work on improving and maintaining optimal functional independence and physical performance. We also work in the area of rehabilitating injury and effects of disease or disability with therapeutic exercise programs and collaborating with caregivers and families. And then we also educate in planning maintenance and support programs to prevent reoccurrence or re-injury and or functional decline. Next slide, please. So there is no cure for EB. We know that there's supportive care for the relief of symptoms from an interdisciplinary team approach, and a physiotherapist is identified as the essential member of the interdisciplinary team. Next slide. So in my experience, when I joined the EB team, the majority of physiotherapy practice was based on sharing what worked and what did not work, collaborating with various healthcare providers, and then also creative problem solving with patients and families. Then I, looked into the literature, and there's very few mention of physical therapy in general, but the time of publication prior to that, there was no evidence-based practices for physiotherapy with people with EB, so specifically with that community. So I reached out, and we've identified that there was a need to establish a foundation of knowledge to guide the international practitioners in how to create and improve our standard of care with the management of physiotherapy practice for persons with EB, which led me to the clinical practice guideline. So next slide. So clinical practice guideline was to provide evidence-based practices and interventions and best clinical practices for physiotherapists when working with a person with EB. And the hope is to then launch future physiotherapy research within the EB community. Next slide. So general overview of the method of a clinical practice guideline is that a scoping survey was sent out to identify what are important components related to physiotherapy interventions, and the survey was provided to patients, healthcare providers, caregivers within the EB community. An international volunteer panel was identified, and then there was a systematic literature review, and then a critical appraisal of the literature, which led to panel meetings for the recommendations that I'm going to present, and then external review of the manuscript and then the publication. Next slide. So I identified 6 areas and the recommendations from the clinical practice guideline. And these are the 6, and I'm going to go over them one at a time. Next slide. The first recommendation is optimizing developmental motor milestone attainment. So starting, evidence leads to that with EB, there's contracture, and with contracture, there's atrophy. So we want to be preventing contractures and atrophy. We want to encourage motor development using a range of therapeutic skills. A physiotherapist can work in modifying different positions. We don't, though we talk about prone, which is tummy time, and we talk about putting them down, and it's very daunting for a new parent, let alone a new parent with the infant with EB. We talk about modifications, different types of materials that we kind of come up with, whatever potential resources are available at the time. We want to talk about preventing new blisters, not causing an unnecessary harm by demonstrating handling techniques and how to hold the child without causing shearing forces. And this care all requires this multidisciplinary team for this interdisciplinary care. Starting in the neonatal intensive care unit is where we first meet these patients. Next slide. So some of the expert practice points from the clinicians and the providers on the panel was that identifying soft surfaces, like the example would be double-lined fabric surfaces or sheepskin, when carrying or cradling an infant from place to place, and then potentially putting additional padding along bony surface when they get to the stage of crawling on the, we've had experiences with placing pads in areas that don't cause additional shearing to provide extra support and cushion. Next slide. So the second recommendation is optimize safe and functional mobility in their natural environment. This across all major subtypes. There's a cumulative risk of developing musculoskeletal contractures in areas other than the hands and feet. And, with decreased mobility, there's a risk that increases with age. We talk about exercise and keeping the feet in good health, aid with assistive device for community ambulation, and then also potential lower extremity prosthesis needed for household ambulation. There's a case study out there. And that we want to emphasize that mobility increases muscle strength and balance and coordination. So in this, we talk about the environment in the sense of like, what can we do in anticipation to prepare for movement in the natural environment? We're talking about mobility devices, how to enhance endurance training through your traditional physical therapy interventions, like stretching and strengthening, balance activities and exercises. We want to educate that the therapist provider can work on these things with the person with EB. Next slide. So then we discuss, wrapping techniques is one example that we want to discuss wrapping techniques in collaboration with the nurses and the families, and how we want to facilitate movement rather than put wraps in a certain particular direction that might restrict movement. We talk about bandages across ankle joints to support neutral position. So, one was to say not to continually wrap in a resting position, which puts the foot and ankle in more of a biased position, not to be able to take weight and develop contractures. Next slide. Third recommendation on how to optimize, enhance, and elevate ambulation endurance and cardiorespiratory function. There's a lot of points on here, but we want to talk about support with weight-bearing activities so that we can prepare for ambulation. We want to talk about mobility and to help with bone mineral content. Provide mobility aids to maintain longer distance and safely perform this. Mobility is positively associated with bone mineral density. It increases bone mineral density, correlated with higher category of weight-bearing activity. Weight-bearing activity and mobility is suggested to be a significant factor in improving bone mineral density. You know, therapists can educate on bone health, weight-bearing types of activities. It's not just standing. You know, there's various components that lead us to this, that we want to maintain this function. We want to work with individuals with EB with significant contractures or palpable yet not tightness that could be prevented or delayed onset, so that we can continue to help support providing regular active exercises. Next slide. So expert practice point is that we want to be able to reach out and educate school personnel, teachers, and assistants, as well as the physical education programs within the schools to help facilitate and share the importance of continued ambulation, and how we can safely do it and support the growth of the student. The next slide. So the fourth recommendation is optimizing ability to safely bear weight. Evidence shows that there should be a full physiotherapy assessment of all the joints, ranges of motions, the muscle power, gross motor ability, and motor development. For infants, knee padding and soft special shoes are required to prevent blistering. This was found in the evidence, which, and then advice, like we can collaborate with our podiatrist, our local orthotist to talk about, you know, supportive braces or footwear as well with families. Orthotics and splints may be necessary with careful choice of materials and considerations needed to help support in utilization in therapy. Again, semi-rigid orthotics are functional and cushioning as they provide support and allow movement. And then there was a case study out there with the use of lower extremity prosthesis, which allowed the person with EB to return to weight-bearing activities. So we're talking about muscle function, muscle power, strength, and material awareness in collaboration with our other healthcare provider colleagues. Next slide. And so the expert practice points that we had was that, again, the individualized assessment is important to guide the recommendation of footwear. We're aware of potential joint restrictions, muscle weaknesses, and things that can help identify the most appropriate footwear and support. We also want to discuss general characteristics of shoe types, footwear, sock material, and provide images of orthotics or prosthetics to potential local resources out in the world to create something biomechanically appropriate for the footwear, as well as engaging the patient in their own personal preference, because that is a key to successful weight bearing. Next slide. So then the fifth recommendation was to improve access to appropriate physiotherapy services. You know, bringing in early rehab consults with frequent reevaluations is recommended for optimal management, if possible, to facilitate weight-bearing independent function. There are specialized EB clinics with comprehensive care, ideally all in one location in certain areas. We also want to say that for those that are non-EB specific physiotherapy practitioners should seek support from these established EB centers, you know, thinking with Deborah Foundations as well to kind of get the information out there. And then again, physiotherapists are recognized as integral members of the multidisciplinary team. And then as physiotherapists too, it is our job to provide education on our role and in collaboration with other healthcare providers. Next slide. And then from expert practice points, we want to say we reach out to educate national and local physiotherapy organizations and chapters about EB. We want to say the physiotherapists to provide education to the EB nurses at the EB centers of their role, and then in collaboration on how we can provide care for our community. And then a component would be to continue knowledge sharing with this DEBRA International Clinical Practice Guideline Network, to potentially collaborate with primary physicians. As we know, it's such a rare disease that I get emails every so often saying, I've never heard of this, what do I do? And then also knowledge sharing information with National Organization of Rare Diseases. Next slide. The sixth recommendation and last is about optimizing overall interaction with environment. The studies show that fostering independence and safety during activities of daily living requires environmental modifications. Some areas physiotherapists can go into the home, in some areas they can go into the school, wherever the natural environment and daily interaction occurs for our community. We want to talk about, there was another case study with the upper extremity prosthesis. So we want to encourage the proper fit, working collaboration with the prosthesis to allow continuation of most activities of daily living to achieve quality of life and functional goals, such as driving, continued driving, and continuation of going and attending work. The case study with the lower leg prosthesis was the ability to achieve full weight bearing even after amputation, with and without the cane, to be able to ambulate within the home and within the community. Next slide. And so expert practice point here is that we want to consider the circumference of the foot and ankle with bandages and our layers and socks when we're talking about engaging and functioning out into the community. You know, during painful wound healing phases that limit functional mobility, we still want to advise use of assistive device, example, manual power wheelchair, to continue optimizing your interaction with the community inside and outside the home. One article is discussing tricycles for children and adults as mobilized scooters is another alternative to wheelchairs that can provide independence, strengthening, increased endurance, and just social interaction in the community. And then at the end of the article, there are some supplementary information to share. These are some standardized assessments and outcomes that I have found with the panel that were used in assessing various stages of the person with EB's status. And then we also provided a physiotherapy evaluation template for persons with EB that we utilize. And so we want to share those. Next slide. And then so this, you know, got many people thinking about future research. And so we brought some up. Here are some pointers from the actual article. Some looking at comparative studies, hopefully in the future, about attainment of gross motor developmental skills between infants with and without EB. We want to look at long-term prospective study regarding mobility devices and duration of independent functional mobility. The validity and reliability of some of these standardized assessments and outcome measures with people living with EB. Identify cardiovascular endurance changes in persons with EB over a designated period of time. And then looking at long-term study of lower extremity range of motion and direction of dressing application to prevent contractures. Next slide. And I wanted to acknowledge DEBRA International, Katya and Olivia, for their support, and our funding body, DEBRA America, and Stanford Children's here. And these are all the other authors and panel members that assisted in the creation of the clinical practice guideline. And last slide. So this Q&A.
Thank you so much, Amy. That was fantastic. It's just amazing to see it now being launched. And I can't see any questions coming up yet. If you're okay for me to ask you maybe one or two. One of my questions would be, what level of grading or the level of evidence that was used for the guideline? Can you make any comments on that?
The grading of... So I think need a little bit clarification, like the grade system that we use, grades of and the strength of the recommendation.
So were they mainly expert opinions, or were they? What sort
Yes.
of level?
They were expert opinion and case studies.
Okay.
Yeah.
Great. And I think my other one was it's compliance. So I'm assuming that normally with physiotherapy, you would have loads of exercises and things. How compliance is, is met with people with EB, because it might be a bit painful. And do you have any suggestions?
Right. I think that really depends on when you meet the patient and understand their current living situations, what their priority is. I've had a range of compliance, I had some family members who dove right in as infants and they tried everything. And, some family members who it's a history in their family. So they're familiar with managing movements with the child. And then I've had some families who it's just, they've understood the balance of like when they're wound healing, that it's okay to not force the child to do things, do exercise. It's okay to, do that one exercise where there's no blisters in that area, but we're still moving. And then I've also had some great clients who went out and pursued a nursing degree and ran marathons, right? Like, but they knew how to manage. This is an older gentleman, of course, but they knew how to manage their blisters in their feet when it came down to all the running. I was even shocked.
Looks like we may have a question up. Can you see it down there?
Yes. Do I recommend passive exercise that can be done without weight bearing for legs in particular? I think it's more of not so much in this nowadays, because we found that passive exercises in research in general, the general population isn't actually supported in the research, but I would kind of enhance it by saying this is more of a bonding moment potentially with the family to kind of, work out and understand the wound healing process and then understand when we can become more active with some of the movement.
Thank you. There's no other questions. I may have a last one.
Sure.
I think it's about the MDT working. Just wonder whether you can enhance, sort of working with, you mentioned podiatrists and nursing. I'm assuming by some of the things you're using, probably OT, occupational therapists. What other sort of important members do you normally relate with?
We work with a dietitian, a nutritionist, social worker, occupational therapist, and then our physicians. We also work actually really closely with the fellows and the residents as they learn about EB, those specifically wanting to go into dermatology. The orthotist and the prosthetist, podiatrist as well, we work closely with. I have been actually starting to work a little bit more with the endocrinologist as well about bone health and learning myself a little bit more, and the orthopedic physicians.
Lovely. Thank you, Amy. I don't think
you.
we have any more questions coming through. Oh, it looks like there's one.
One more.
Do you have time, yes, to answer this one?
Yeah, I do. Do you have a lot of problems with patients being on devices a lot? I think of two things nowadays: devices as in like iPads, or devices as in DME, like durable medical device, I think. I don't have that many issues with my clients being dependent on, like, I'm just going to go with this one, the wheelchair. I hope I'm answering your question in the sense of being dependent on that. I do strongly emphasize, and with families, a lot of education about letting them move, letting the patients explore. There is going to be times where they need to be on in their wheelchair per se at school, especially if they have active wounds or blisters on their feet. I'd rather than be able to be in the wheelchair, go out and engage with their friends, than cause more pain and have them, sitting in the room. I try to emphasize this with families, that it's really important to have a lot of social development too as well.
Thank you. Did that Did I answer your question, Sharon? Great. Thank you so much, Amy. It's been fantastic. And
Thank you.
We'll be in touch. And thank you everyone for joining our
Sorry,
first
can
webinar
I just,
this year.
sorry, Katia, there's just one more question that's come up in the chat. I don't know if we could just quickly answer that one.
Oh.
I've just seen it come up.
Oh, in the chat.
In the chat, yeah.
Can you see it, Amy?
Oh, it's from David, yeah. So unfortunately, there are not any physiotherapy recommendations from the evidence that we found about oral scarring. Just as a therapist that I work with infants, and I've learned from my speech pathologist colleagues and my occupational therapists who work a lot on feeding and oral motor skills, that, you know, with the movement of the mouth, we talk to families just about practicing and maintaining opening. The one thing I do is I just do a measurement of if there's available teeth, how far they open. So I track that over time, and I provide that information at our follow-up rounds.
Thank you. Did that address the question? Great. Thank you, Amy. I know
Thank you, everybody.
Take care. Thank you, everyone, for joining us.